I'm Dr. Shim. I work at Wright State. I'm part of the Wright State Physicians Group. I primarily work out of Miami Valley Hospital, but I also see patients at Miami Valley South in Centerville. The reason we're doing this is we sort of do this sort of monthly seminar from the Wright State Physicians Group for the public, just to get people to think about what procedures are out there for patients, what the newest technology is, and also what non-surgical options there are with bariatric patients. So we're going to go over a lot of things, but at any time, if you have any questions, you can always ask me. This is an open forum. Utilize your resource. I'm here for free, so ask me anything. If you have any questions, like I said, just ask away. So today we're going to talk about bariatric surgery. We're going to talk about what is bariatric surgery, the safety and the concerns of current procedures, the long-term outcomes, everyone always talks about that, the efficacy, does it work, and the future of bariatric surgery. So bariatric surgery, the whole point is it's a tool. If it was easy, everyone would do it. It's not easy. I always tell patients that the surgery you choose, it's a kickstart. It's really a surgical kickstart to help facilitate weight loss. But to maintain it for the rest of your life, you have to work for it. And you're using that surgery as a tool. Okay? And that has to be really understood. People think, oh, I had surgery. I'm automatically going to be normal weight, whatever that is for you, and be done with it. It's not that simple. I think all of us know people who have had bariatric surgery who's lost weight the first 2 years and then regain it all back. And you're wondering, how is that possible? We're going to go over that, but it is. And it's because of lack of education, and the reason is the people did not use that surgery as a tool. What I look at success as patients who are 5, 10 years out, and they still have maintained their weight, their goal weight. So the whole point of this procedure is that we're reducing the size of your stomach, right? It's a reduction. And the whole point is you eat less food, right? So we follow the NIH guidelines, which was published in 1991. It was a consensus. And we base it upon BMI. What is BMI? It stands for Body Mass Index. Body Mass Index is calculated using your weight, multiplied by that number, and we get this. So in the United States, according to this guideline, you're considered obese if your BMI is greater than 30. You're severely obese if you're 35 to 40, 39.9, they're very specific. Super obese if your BMI is over 50. Now, what causes obesity? How does a patient get from a certain weight to obesity or super obesity? Is it social? Is it genetics? Is it an interplay of many things? We're still trying to understand that. Why is it that in 2016, it's an epidemic that 1 in 3 adults have considered obese? Not even overweight, obese. How come we didn't have that problem in the 1920s? So there's an interplay of many things that's contributing to this problem in our society. As you know, with obesity, it's a significant contributor for stroke, heart disease, diabetes, some types of cancer. You have an increased rate for infertility, sleep apnea, diabetes, high blood pressure, respiratory problems. I don't think I need to tell you this because I think everyone knows. And the complications I just listed. Now, what about metabolic syndrome? So if you are someone who has abdominal obesity, measurement, 40 inches for men and 35 inches for women, you have high blood pressure, your blood glucose is high, right? If you have a low level of HDL, which is the good cholesterol, or high serum triglyceride, if you have 3 of these, you're considered someone who has metabolic syndrome. Okay? These are the consequences of obesity. And I just went over, but this picture captures really people who have surgery, bariatric surgery, they find improvement. Oftentimes I see patients in clinic, they're on 10, 15 medications. And they always tell me that that's not a quality of life that they have sought out for themselves. And they want to know that they can get out of taking from 5 insulin to 1. For them, that's an improvement, quality of improvement. And as you can see with weight loss, and especially weight loss surgery, you can see all these medical problems that go with obesity, there's improvement. So that's why a lot of patients decide to have surgery, because they want to get better with their other medical comorbidities, which is a fancy word for saying you have high blood pressure, diabetes, sleep apnea. What about quality of life? You just want to go outside and go walking with your family and not be short of breath. So obesity today is very costly, exceeds $61 billion annually. Obesity is responsible for approximately 112,000 preventable deaths annually. I think this map is going to really capture the problem. So this was taken out from the NIH website. If you look at 1988, let's focus for now, Ohio. So you have Ohio, and according to the map of Ohio, 10 to 14% of adults were considered obese. So let's follow that. This is 1988. You go to 2010, right? Look at the color now. We're at 25 to 29% obesity trend just for the state of Ohio. Look at Texas and all the southern states. They're at greater than 30%. Right now, this is the latest data that's online. You can see that Ohio is between 25 to 30%, but there are certain states, specifically Alabama, Mississippi, and Louisiana, that's greater than 35% of adults in that population are considered obese. Not overweight, but obese. So it's a true epidemic.
Is there anywhere that was 20% or below?
What a great question. I don't see one. Does anyone else see one? No. So it's very upsetting. And this is adults. Imagine, so 65, overall in the United States, the prevalence of obesity was 65.5% among U.S. adults during 2011 to 2014. Overall, and then they show you the age group, and then splits it between men and women. But you can see that it's anywhere from 30 to 40%, which is unacceptable, right? What about children? So children are affected as well. You know, the parents, they're the ones who go grocery shopping. Their habits are also affecting the children. And if you look at this, the prevalence of U.S. Youth was 17%. And that's unacceptable as well. That they divided between, I'm sorry that the slide is not complete, you can't see the bottom, but depending on the age group, 2 to 5-year-old, 8.9%. How is that acceptable? So this just tells you the pattern that we're dealing with in our country. This is very serious.
Do other countries have this issue?
What a great question. Yes. So they're seeing it in China, in Europe, South America. So yes, it's worldwide because we are a global society now. But obviously we're in the United States, so our focus is here. But bariatric surgery is done internationally. Yes. So what's a typical fast food meal? You know, you go to the McDonald's, a Big Mac is $540, large fries, and a Coke. You basically have your entire day meal just with that one meal. And I think, especially the youth, they don't realize what they're putting in. And it adds up, and it keeps adding up, and it obviously contributes. So it's calorie in, calories out. So you've come to a decision that, you know what, I don't like this. I don't like the weight I'm in. I've struggled with it my whole life. I don't want to live this way. What can I do? And some patients decide they want to have surgery. And the decision to have surgery, the decision to see a surgeon, is a huge decision. It's not easy because we're not meant to cut stomach. We're not meant to reroute the GI system. That's not why we were intended. But we do it because we have a tool that we can use for weight loss. And that's what patients decide on. Why? I think the most important thing is to improve life. mission do this if I wasn't going to improve someone's life? Maybe I'm selfish, but I want to improve someone's life, not worsen that person's life. So quality of life improvement is the most important thing, I think. Social and emotional benefits. This is a very complex thing that we're dealing with. It's not just the medical problem, it's the interaction with others, with your family. Eating is part of life. That's completely going to be affected, whatever surgery you choose. And also, you have to look at the risks and benefits. Every patient is different, and I think what I enjoy about bariatric surgery is it's personalized, that every person has a different medical problem, every person had a different reason for being overweight or obese. So those things have to be addressed and continue to be addressed even after surgery. So people always say, well, why are you getting surgery? Why not just go to the gym, diet and exercise? Everyone else does it. Go to CrossFit. This thing is so popular. Well, I can tell you by statistics, 1 in 20 lose weight with diet and exercise, and that's not even sustained. So it just tells you the real struggle. It's a true struggle, even with diet and exercise. People make it sound like it's so easy, but it's not easy. And that's why all these different programs, like Jenny Craig and Curves, they make so much money. Because people pour money into that, but where's the benefit? It's short term. Usually those, most patients have a really, I don't want to negate the fact that some people are successful, but that's very far and few. So I want to tell you, you're here, I'm a surgeon, I'm going to inform you of the options that are out there for the public. So there are 3 surgeries. There are other surgeries, but today we're going to focus on 3. That is most popular, that is done in the United States. The first one is the gastric bypass, which we're going to go over, the laparoscopic band, and the sleeve gastrectomy. In the United States, the Roux-en-Y gastric bypass is considered the gold standard, and I'll explain why. But these are the 3 surgeries that are most commonly offered. I can tell you with conviction that the band, which is the second one listed, is probably going to go out of phase, at least in the United States. Patients have not done well with it. Patients have gotten that removed, and most surgeons don't offer it. I think at our facility, less than 10 patients got it last year, and I can tell you personally, I don't offer it. In fact, I've removed more of it than placed one. So I know that if it was my brother, my sister, I would not put a band, unless there's some new technology that shows up that shows sort of improvement. I have not seen someone do well with it. And the whole point of whatever surgical treatment we choose, we want to choose it so that it's the first time and last time. We don't want to keep going back. None of this is easy decision, but we want to make the right decision for you. So for you, your body, it may be a sleeve. For you, it may be a bypass, but it has to be personalized. Whatever decision that is, even if it's a little bit more serious surgery, may be the best option for you, right? Because you're trying to choose what's the best tool for me and my eating habits. So, boy, in 1991, a surgeon performed a laparoscopic Roux-en-Y gastric bypass. I say that because look at this picture. Before 1991, they did a big incision, a big midline incision, so huge, a lot of pain, and also possibility for a hernia. But with the advancement of laparoscopic surgery, which are small incisions using camera, sticks, I operate with sticks is what I tell patients, smaller incisions, less pain, faster recovery. And that is laparoscopic procedure. So gastric bypass. Why is this called Roux-en-Y gastric bypass? There is no mystery. The word Roux-en-Y. Why is it called a Roux-en-Y? Because this limb is called a roux, and it looks like a Y, and that's why it's called a Roux-en-Y. Gastric bypass. Gastric is a fancy word for saying stomach, and this stomach is bypassed, like the highway. You're bypassing a certain area, and so with your new anatomy, meaning your new intestinal tract, what happens is you eat food, it goes down your esophagus to this tiny little stomach. It's so tiny that I'm going to just give you sort of, because most people are visual, this is about 500 ml. So all of us in this room is capable of having 2 bottles of water in our stomach, about a liter. After the gastric bypass, you see this cap, probably 3 or 4 of this cap is your new stomach. So it's a huge reduction. It's a huge restriction. And you're wondering, well, doctor, can I live that way? Is that possible? Yes, because you're not going to be eating 3 large meals anymore. Instead you're going to space it out to 5 meals a day. And you're going to take protein shakes. It's a different way of life. And some people don't like that. And so they don't choose that. And you have to be informed before you make that decision. Because it's a huge commitment on your part and also the surgeon. But that's the kind of drastic change they want for themselves. Because they're tired of being obese, right? That's the whole point. So you eat food, it goes to your small pouch. I'm going to call it a pouch, but it's your new stomach. It goes through this intestine, and then the absorption starts here. Now you're saying, okay, well, why doesn't this stomach get removed? Why is it just left there? It's left there because this is still excreting hormones and enzymes. And so we leave it there, and it's called a remnant stomach. And all of this has the bile, the biliary juice, the pancreatic juice that comes down where we can start doing the absorption here. So this surgery is effective for 2 reasons. Tiny little stomach, then the absorption is delayed. So it's called malabsorption. Why is this the gold standard? It's the older operation. It's been researched. It's been proven that it has been effective for people with diabetes, especially people with high blood pressure, sleep apnea. So that's why it's considered the gold standard. Now, what about the risk? No surgery is easy. This is not a simple operation. There's 2 new connections. So the first thing we always tell patients, the number one thing we worry about is leak. We don't want any leakage, right? Is it common? No, it's very rare. If it was common, why would I do it? No one wants to have complication, but you need to be aware that it's possible. It is possible. It's less than 1% of patients, but that's possible. What about bleeding? Of course, you're cutting. 1 to 2% pulmonary embolism, which means you have a clot that can actually migrate up and cause something called a pulmonary embolism. So we're very aggressive about patients walking after surgery. Bowel obstruction, meaning there's an obstruction in your intestinal tract. You can have narrowing with the connection. That's a fancy word for that. And can patients die from this operation? That's very rare, but it can happen with any surgery. And this is general surgery. You're going to get general anesthesia. I don't want to scare people. The whole point is to be informed, because it's your body. You need to know what decision you're making before and after. So that's when that surgery. Now, sleeve gastrectomy. Boy, this is so popular in the United States. It's actually superseded the gastric bypass. Everyone's getting sleeves. And I wonder why. It's because there's no rerouting. You're just making the stomach smaller. I tell patients, you're making the stomach into a banana or a sleeve, but people like banana. So again, your normal stomach, I'm just using very general, everybody may be different, but overall, 2 bottles, goes from 2 bottles to maybe 5 to 6 caps of these. So anywhere from 90 milliliters to 150 milliliters is a new volume from 1,000. So you still have restriction. This sleeve gastrectomy, I'm going to say something, which is, it's the longest staple line in general surgery case. The longest staple line. We're stapling the entire part of that stomach, right? And so yes, you have a reduction, but the reason I brought that up is you have a higher chance for a leak because you have a longer staple line. And again, is this common? No, it's not. But can it happen? Yes, it can. As a surgeon, what do I do to prevent that from happening? Not only do we use staples, there's buttresses. We also laparoscopically suture that area. Sometimes we bring in what we call an omentum, which is sort of the apron of our body, and we bring that up and tack it along. We do all these things to prevent it from happening, but at the end of the day, there are certain things we can't control, and we don't know who that patient's going to be with all these precautions. But the big picture is it is not common. It is not common, but it can happen. The other reason why, like I said, the patients prefer the sleeve gastrectomy is because of the lack. There's no rerouting. There's no new connection. You're just making the stomach smaller. Okay. Obviously, you can bleed because you're cutting through stomach, and the stomach is very vascularized, and then that. What about band? I'm not going to even spend that much time unless somebody wants me to talk about it. But the band, it's the design of it is, I tell patients it's like having a belt over your stomach, and every 6 weeks you come and get your buckle adjusted. Okay? So you have a belt around the cardia of your stomach. Come in every 6 weeks. We put a Huber needle across and find the port and inject some saline to give you more restriction. The reason that it's not as successful for a lot of patients, number one, patients don't show up for follow-up. So they have the band and they think that's good enough, and it's not. The other complication is this band can move, slip. It can erode to the stomach, cause perforation. So because it's a foreign body, even though it's silicone-based. So given all the complications, and also bottom line, no success with weight loss, there's really no point to really advocate for this. But as a bariatric program, we have to acknowledge and give you all your options. And as an informed patient, you make that decision for yourself. So what are the criteria? Do you have to be a certain weight and then do you get scheduled for surgery? No, it's not easy like that. There's a lot of steps that have to be taken to even, first of all, consider bariatric surgery and be qualified for surgery. For starters, you have to meet the NIH, National Institute of Health criteria, which is your BMI, your body mass index, has to be greater than 35 with comorbidities. What does comorbidities mean? High blood pressure, diabetes, sleep apnea, high cholesterol. The list can go on, right? Or your body mass index is greater than 40 with no comorbidities. No alcohol or drug problems. Psychological conditions that are uncontrolled. We have a team, and the whole team has to have a consensus that you are the right person for the program, and you have to be dedicated. I'm committed as a surgeon, but the patient has to be committed. That number one, they want change with surgery and change thereafter. That they recognize that the surgery is just a surgical tool, but to be successful and maintain it for lifelong, they have to make a lifestyle change. And that they're going to continue to show up to see the nutritionist, continue to take ownership of their health, right? So those are the criteria. So patients always say, well, Dr. Shim, I'm 250 pounds. Does that mean I get a sleeve? I'm 450. Should I get a bypass? It's not that easy. It really isn't. We can't match the exact weight for each procedure. I think it's all about each person. It should be individualized. People come in with different medical problems, and so as a team, meaning a doctor, the nurse, the dietitian, the psychologist, and the patient have to talk and decide what's best for the patient. And the patient, at the end of the day, has to choose what's going to work for them because you're deciding the tool, right? So usually how this pathway, so what's a bariatric pathway? People always talk about that. So the initial referral, so you need a referral from your primary care doctor. You're going to have a discussion, say, listen, Dr. Smith, I've struggled with weight all my adult life. I don't know what happened, but I hit 21 and I've just been struggling with it. And I've done everything from Atkins diet to protein shakes, exercise, CrossFit. I lose 20, 30 pounds, but then I regain it or I regain it all back. So I don't know what to do. Well, then your primary care said, well, let's refer you to a bariatric surgeon in town. Then you go to an introductory seminar where you listen and really get the entire vision of the program and understand the options of what we're going through right now, basically, okay? Then you're going to have a consultation with the surgeon and talk about you, individualize it to you. Why are you here? How did you get here? Meaning, how did your journey take you to this part of your life now? And then go through all the different medical criteria. So you'll see a dietitian, a psychologist. You'll make sure some people have to get cardiac clearance, respiratory, pulmonologists if they have sleep apnea, gynecologists for women of childbearing age, because oftentimes they have infertility issues or they have menorrhagia, which is heavy bleeding. So everyone has different people they have to see. You get labs and studies. And then at the end, when all this is done, the checklist is done, you come back to clinic and we decide what surgery you've decided for yourself, and we decide on a surgery date. That's how it happens. And so patients are always saying, okay, I just saw you today, when is this happening? Unfortunately, it's all about insurance. So that depends on, every insurance is different. Some insurances require documentation that you've seen a dietitian for 3 months, that you've tried the conservative measures. Every insurance is different, but we're going to work with you if that's what you want. If you truly want this, we're going to definitely work with you. But to have expectation that you go in and have surgery, I think, is not being forthright. And the other thing is, I personally strongly believe in education. You have to understand what decision you're making before you just do it. I really believe in that. I believe in transparency. And I also believe in confidence of the surgeon as well as the team, because they're going to be lifelong members of your healthcare. If you don't trust your surgeon, then what else is there? It doesn't matter. I'm a general surgeon. I do hernias too. I tell my patients the same thing. You must have confidence in wherever you choose. So the surgery is elective. This is not trauma where there's a gunshot and we need to race to the operating room. We can have pauses, we can think about it, talk about it, and then decide what's best for you. Okay? What happens after you have surgery? What's next? You follow up consistently. You're thinking, why do I have to follow up with the surgeon all the time? Because you need to make sure, remember, you're losing a lot of weight. You're going to be on vitamins for the rest of your life. Okay? You have to make sure your protein level is correct. You have to make sure all the different vitamin levels are correct. So you get lab draws. You see periodically to make sure you're right on track. And remember, especially with the gastric bypass, there can be trouble along the way. And the whole point is prevention before trouble lurks. So for me, I'm all about prevention, education. Because I think if those two things are done appropriately, everything else that happens, we've done the best we can, right? But if we don't do the education and the prevention, then we're just asking for things to happen after surgery. And so these are the labs that we periodically check after surgery. Most of them are vitamin levels. What about protein? You have this tiny little stomach. How can I eat? I can't have what I used to eat. How can I maintain a life? I'm going to pass out all the time. No, you're not. You're going to take protein shakes and try to get at least 60 to 80 grams of protein a day. You're going to hydrate yourself constantly. Most of my bariatric patients have a water bottle with them all the time, sipping. And you're going to take your supplements. Now, let's talk about this. Who are these people that I call them non-responders? They go through the surgery and, they lose weight the first year and a half, but then they're stalling or they regain it. What happened? Number one, counseling, education. They did not get the appropriate education. They didn't realize that they were really getting a tool, not something that's going to fix everything for them. No follow-up. They had surgery and then they never saw the surgeon again. They left town. Maybe they had to, but they never followed up with the surgeon, a bariatric surgeon. Non-compliance. I just went over it. You got to take all this. But then they show up in clinic and say, yeah, I don't even know what vitamins you're talking about. That's not good, right? We have to all be on the same page. Because what's with the vitamin? Who cared? Why is this such a big deal with bariatrics? Remember, you're not taking the same nutrients like you used to, right? And especially the gastric bypass, a lot of the absorption happens in the first part of the intestine and you bypass that. So even if you're doing well eating, even after the surgery, you're not going to get the nutrients that you need. And so you have to take it because of the surgery, not because of what you're eating. It's the surgery. So you have to be on these vitamins. And what if you say, you know what, I'm on on vacation, I don't feel like taking 10 of my bottles with, I mean, I'm exaggerating, but all these bottles with me. Well, you know what? For example, if you end up being B12 deficient, you can have permanent issues neurologically, okay? Peripheral neuropathies. Patients who have vitamin B1, thiamine levels that are low, they can have neurological consequences that are permanent as well. So you have to be very mindful that some people don't want that. Some people don't want to have to take vitamins for the rest of their lives, and that might be something that forces them to not have surgery because they just don't want to take the vitamins. I mean, everyone's different, and everyone has to make their personal decisions, but you need to be aware of this. That it's not, okay, I'm 5 years out, I don't need to do this. Yes, you do. And I'm being harsh and I'm being direct because it's important. If it wasn't important, I wouldn't take the time talking about it. What about social risk? You know, I'm going to tell you that I was in the military. I was at Fort Campbell, and I did bariatric surgery there. And a lot of my patients were dependents, wives of our soldiers. And a lot of those young women, they have kids early on, or some of them have struggled with weight all their lives. And what happens? Their confidence is low, depression sets in, their husbands are away for 15 months. They see me in clinic, they're 300 pounds, they have surgery, they lose weight, and everything surfaces. Number 2 and number 3 are huge in the Army after weight loss surgery. I put that because that's human nature. When you physically change and it doesn't catch up with you emotionally and mentally, things surface. So do not be surprised that these things will come and surface for you. And I think for me as a surgeon, I love operating, but the reason I love bariatric surgery is it really looks at the human condition, the disease process, but also the mental health, the emotional health, even spiritual health, everything. It really, and it affects everyone, the whole family, because again, eating is part of life. So you need to be aware of that there are these social risks. So, you know, some people say that, I put misconception. Some people say that, you know, again, regain. And patients always ask me, Dr. Shim, I'm 300 pounds, I want to be 125 pounds by 2 years. And I said, that's not realistic. That's not realistic because the goal weight we want is at least 50% of your excess body weight loss, right? And that's different for every person because you want to be able to maintain it. Fine, you get to your goal weight, but can you maintain that? That might not be for you. If you're 300 pounds, you may be okay with being at 200 pounds because that's what your body's capable of maintaining, not 125 pounds. So you have to be very realistic with weight goals. And remember, 125 pounds does not equal healthy. Healthy is when you're off of all your meds, when you're not a diabetic, when your hemoglobin A1C is normalized. That's healthy. The number gauges where you are, but when you have energy to walk outside and go hiking and enjoy the seasonal changes, that's success. Not being a certain weight because of number schemes. So I know it's weird because you get the surgery approval because of a certain number, but then afterwards, because that's what I'm saying, everything's very fluid with the surgery. It's not as concrete because there's a lot of things that play a role in weight loss and dynamics of life. What about, you know, the public? People are thinking, what a cop-out. Why can't you just go to the gym? Why don't you just walk around and stop eating? I'm just going to tell you right now, it is not a cop-out because if you explain to people, listen, I had the surgery because I'm using it as a tool, what else can you say? I am getting a surgical tool, meaning I'm going to utilize this new tool I've gotten to help me kickstart my weight loss. One of the new technologies I wanted to talk about is intragastric balloon. So this has been around for 20 years, and they've done over 200,000 patients worldwide, and over 80 countries have performed this. In Ohio, first of all, this was approved in the United States by the FDA approved last year in August of 2015. And what I'm going to call this is it's a space occupier. It's occupying the space of your stomach. And how much fluid can this balloon that's based by silicone take? About 500 to 600 milliliters. So a bottle of this is going to be in your stomach. But obviously it's not in the shape of this. It's the shape of a sphere. And how does it work? Well, I'm going to give an example. In Brazil, it's popular because women use it for pre-wedding weight loss. Or women in Europe use it for post-pregnancy weight loss after having 2-3 children. So this is done, it's non-surgical, it's done endoscopically where they put a scope down. When you get a colonoscopy, we do an endoscopy above, and it's implanted and it's lodged at the body of your stomach, and it stays there for 6 months. And during that time, you'll meet with a dietitian, and this is the new Kickstart, the tool that you're going to lose the weight. But this is not a simple fix either. Remember, this is a different kind of tool. And some patients prefer to try that before trying to do the cutting and the rerouting. But what I need to be honest and truthful with you is that this is out of pocket. So this is not accessible to everybody because not everyone can afford this. It can be anywhere from $7,000 to $10,000, and insurance doesn't pay for it. Are there people who are doing it because they're desperate? Yes. Yes, they are. But it's not for everybody. And the whole point is, when you look at the entire umbrella of bariatric surgery, you want it accessible to the public. But there's different tools that are available depending on your lifestyle and what you need.
How long term would that be?
This balloon?
Yeah.
So it's in your stomach for 6 months, and then you take it out. And in terms of success rate, they've seen mild to moderate success rate. Success rate meaning losing about 20 pounds, 10 pounds. That's why I just called it the pre-wedding, post-pregnancy weight loss. It's good for people who are, 220 pounds, 210 pounds. They just need a kickstart. And the whole point is, I never want to close the door on any new technology because if it's going to be a tool that someone can use, then we should offer it, and we should make it available or educate the public. But you need to be aware of all the different tools that are out there before you make a final decision for yourself. I think that's the key. The key is education. Knowing wholeheartedly what decision you're making for yourself. I think that's it. Does anybody have any questions or comments about, or anything that they learned today that they were surprised about? Yes, sir.
Medicare, do they pay for it?
Yes, they do.
How long, how quick does the weight, what's expected, I guess? I mean, like you said, it's unique, but is there some...
With the balloon or just in any of the surgeries?
Just the regular thing, yeah.
Right.
Not the balloon seems, if it's only 20 pounds,
Yeah.
that's a... Hell, I could stop eating and get that. I mean, so that would be stupid to spend $7,000 or 10. So on the, like, say the gold standard, I guess
The Roux-en-Y gastric bypass.
yeah. So how quick do you lose weight?
Pretty fast the first year. The first year and a half, you don't have to do much and you'll start losing it because you're eating less. Imagine going from a huge volume, 2 bottles of water, to capfuls. No matter, if you don't do anything, you'll lose it immediately because you have that restriction and that malabsorption. Usually what I say is 50% of your excess body weight, so we would have to calculate your weight and figure that out. But I could give you an example. A standard person who's about 300 pounds, by 2 years out, they should be 200 or less.
The eating sounded kind of troublesome.
Yeah.
I mean, 5 times... I mean, if you're got something going, it's a pain in the butt to have to.
You're absolutely right, and these are the decisions you have to understand before you make that decision. If for you can't live that way, then it's not for you. It should never be forced. This is an elective operation. And it's a decision you're making for yourself and your family. So I agree with you. It may not be for everybody. If you feel strongly about a certain diet and the timing and all of that. Because, again, this is a tool. You're educated. You've made that decision, and you're going to go with it.
These protein shakes, I don't know what the hell they are. I mean,
The protein shakes?
Yeah.
There are different types of protein shakes with different companies. I'm going to use an easy one. Boost, Ensure, Premier. There's so many brands. Bariatric Advantage. And they all come with different grams of protein. But big picture, it's expected that you take between 60 to 80 grams per day of protein.
how much it, grams don't mean crap to me. I'm American. I have no clue about
Well, you would go-
metric system.
You would go, that's great. You would go over that with the dietitian. Yeah.
Before surgery,
Yeah.
I heard that you have to go on like a liquid diet before that. Is that true?
What a great
About
question.
A month
Yes.
or so out.
Yep. So usually 2 weeks, but some people ask for 4 weeks, and the whole point of that is to shrink that liver. If the liver is very heavy, because we have to laparoscopically lift the left lobe of the liver, if it's heavy, it can bleed. We don't want bleeding. You're helping the surgeon. That's why we ask. Plus, it's a good way to kickstart your new life.
The vitamins that you have to take.
Yes.
Sometimes when I take vitamins, they upset my stomach. So now that I am going to have a smaller stomach, are those vitamins going to be even more upsetting and causing, GERD and things like that?
That's such a great question. So, oftentimes, patients who have weight issues, reflux comes sort of together. And oftentimes, after surgery, it resolves. But, the question is, are the vitamins, because you're already very sensitive to it, will it get worse? I can't guarantee that, but there are different bariatric companies that specifically make vitamins for bariatric population where they coat it, where it can just dissolve on your tongue.
Okay.
So there are other options or liquid forms. So if that's your biggest concern, then what I would do is research on the different, but I can tell you there's liquid forms, dissolvable, because you're not alone. There are other people like that.
Sure. Now, what about people that are of childbearing age? As far as folic acid and things like that, is it something that you would recommend for people, especially like women and why, prior to having children? Will they be able to absorb enough nutrients as
Great
they're
question.
entering their
So,
life?
especially with childbearing age, and I can tell you that, especially in the military, there were women that were infertile. They could not have children, but after the weight loss, they were able to have children. And the recommendation is after surgery, you should not get pregnant for 2 years, even if you want to. Because, I just say that as a general statement.
Sure.
Because you're trying to lose weight.
Yeah.
So you want your body to adjust to everything. And then after 2 years, you're okay with getting pregnant. And during the pregnancy, you would see not just the OBGYN, but also a bariatric surgeon to make sure your vitamin levels are safe for you and your baby. And that you are having a safe pregnancy. But yes, you sometimes need to double up on some of the doses to make sure that you're on the right level. So what a great question. So pregnancy and bariatrics, that's a special subgroup that has to have a team effort during your pregnancy. Especially if you had a Roux-en-Y gastric bypass. I feel very strongly about that. And remember, 80% of the U.S. population who decide to have bariatric surgery are women. So that pregnancy is it plays a huge role.
Now, I looked at Roux-en-Y probably 10 years ago, 15 years ago, and decided against it because they told me that because of the way that everything was going to be bypassed, that there were certain foods that I could no longer eat. And this is going to sound crazy, but the one thing that I'm like, I can't live without that, it was ketchup. They said, you will not be able to digest ketchup. And I'm like, but I like it on my eggs, or I like it, just a little bit. Do they still have problems with certain foods that you just cannot?
That's such a great question. I can tell you that I don't have a crystal ball because there are patients who are able to tolerate beef jerky, but then they can't tolerate I don't know, some random food. So everyone's different.
Okay.
The suggestion, the big picture is we don't want you to have dumping syndrome.
That's
So
what I remember.
so
yes.
ketchup, unfortunately, I know we all love ketchup, but its sugar is high. And so if it's greater than 5 grams, there's a high chance
Of that
for a dumping syndrome. But some people need dumping syndrome to get that negative feedback because then they feel ill and they're like, oh, then I shouldn't have that chocolate cake or that.
Exactly.
So some people need that negative feedback. They like it. That.
Can you explain the dumping
Yeah.
syndrome? Because I don't know.
So the dumping syndrome is, the only way I can show it is by showing you the picture. This bypass, this is called the jejunum, okay, which is a special word for an intestine. So in our small intestine, we have the duodenum, the jejunum, and the ileum. This new stomach is attached to the jejunum. Now, this jejunum, our friend, is not used to seeing food right away because it sees it once it's all processed. But this jejunum is now seeing food that are fresh. And especially high sugar levels, it can cause patients to get deathly ill because of that connection. So that's why it's extremely important as a gastric bypass, not a sleeve, but a bypass because of that jejunum, seeing that high sugar. So for that reason, you want to avoid high sugar rate food.
So if you're doing that, you're not going to be eating chocolate cake.
You're not. But interestingly enough, your body does adapt over time,
Sure.
and patients are able to, but the first couple of years. And I gotta tell you, some patients have surprised me that, they have the gastric bypass and they did sneak in a ketchup and they never had dumping syndrome. So
It just depends on.
it really depends on the patient, but overall, big picture, the recommendation is less than 5 grams per serving of sugar because of the dumping syndrome. Dumping syndrome is a syndrome. So you get nausea, vomiting, deathly ill, flushing. You want to just crawl down and lay down. And
Say, I'm never doing that again.
yeah. But everyone has different symptoms with that. But it's because of the high content of carbohydrates that are seen by the jejunum. The jejunum does not like it, the intestine.
If you get that, whatever you call it, where you want to upchuck or whatever, it seems like early on, if you had that problem, it could be a problem for all those connections that are not done yet. The staples and all that stuff, that jerking, could,
The dry heaving?
yeah, rip you apart.
Right. Questions?
So you don't, I'm still a little hazy, you don't eat normal food?
You eat normal food, but small bites, and you chew 20 times. You have small stomachs, you can't engulf a hamburger in 1 bite, right? Or 2 bites. Some people are able to do that. So you would have 1/4 of it and have small cuts and eat it in small portions because you're visualizing your new small stomach, right?
Does it tell you? Does it give you a hint that
Oh yeah,
stop?
you'll feel full. Absolutely,
okay.
You'll feel that restriction. Even if you want to push it, you can't because you'll feel full. Well, those are all very good questions. Anything else you guys can think of? Well, thanks for coming. I think that this is just the start of a dialogue, and again, it's all about being informed of the different options and deciding what's best for you at the end of the day.
Is there any age restrictions?
What a great
after a
question.
certain age,
Yeah.
they don't want you to do
I'm going to tell
anything.
you right now, a couple years ago, yes, there was. Before 60, if you were after 65, no. But now, no more!
Really?
Yeah, the age restriction is lifted by the ASMBS. So, patients are living longer. It's not fair. There are people, who are 74 who are hiking 10, 15 miles. And then there are 30-something-year-olds who can't hike 1 mile. So it's